Thank you very much. It's really a pleasure and a privilege to share some of the work that we have done by doing this review. My gratitude to Julie to have lead it and to AIs that have given the opportunity to us to doing this. Sickle cell disease originated in Africa about 7,000 years ago, at least, and it's a condition associated with resistance to malaria. But it get recognized to modern medicine about only 111 years ago in American student. And since the discovery of sickle cell disease, many important landmark of research started with Louis Pauling that described the mutation to the description of haplotype by Kazesian, to the repartition global of haplotype suggesting multiple origin by my personal mentor, Stylianos Antonorakis. And I hope that we will contribute to this work in the many years to come of our career. This condition become extremely prevalent on the continent because of resistance to malaria, and of the nearly 300,000 new babies of sickle cell disease that are born in the world, about 80% are born on the African continent. And it's a condition associated to the mutation that distort the red blood cell, giving them a shape of a banana. And these red blood cells become rigid under the oxygenation and become crystallized. The reason why they will tend to obstruct red blood cell. These red blood cells, these banana cells, are also prone to destruction. They live very less than the normal red blood cell, and that will lead to anemia. So anemia, organ failure, susceptibility to infection are the main complication of sickle cell disease, and this can be summarized like this. So this patient will be subjected to major cardiovascular complication like stroke, much more than in the general population. This is an example of the image of stroke in a real patient with sickle cell disease. And in sickle cell disease, we can observe both hemorrhagic stroke on the left-hand side and also ischemic stroke and described on the right-hand side of your screen. And these stroke events, unfortunately, jeopardize the progress of the child and their capacity to respond to executive function as measured, for example, in Cameroon, through evaluation of cognitive deficit that clearly become to be different between sickle cell disease patient and control from year 10. That means that interventions for care and prevention should happen much more earlier in life of these children. For all too recently, there was no definitive treatment for sickle cell disease, and most treatment at the moment, and it is the case in most African countries, as we have seen in the review, are based on pain, antibiotic therapy, transfusion, and rehydration. But we know that evolving treatment that unfortunately are not yet available in most African countries are based on anti-adhesion, augmentation of fetal hemoglobin, for example, using hydroxyurea, on bone marrow transplantation that are available in only a few African countries, actually to Nigeria and South Africa, and be developed at the moment in Tanzania, and gene editing and gene therapy that have become increasingly maybe the future of sickle cell disease cure. So we are proposing the review a few guidelines that are very flexible for sickle cell disease cure on the African continent. But this guideline will not be useful if we do not have enough specialized center of sickle cell disease care on the continent. And this slide that you will see in that paper describe the country that have a comprehensive care centers on the left-hand side. And you can see that most sub-Saharan African country will not have a comprehensive, specialized comprehensive care center for sickle cell disease. And only 2 actually have effective care center for stem cell transplantation. And Tanzania hopefully will be having their capacity of doing those transplantation recently. I must stress that the capacity of doing hematopoietic transplant will be an important capacity to implement gene editing or gene therapy for sickle cell disease. So we will need to improve this map in the years to come. So what we have left is screening strategy that can be at the neonatal level, and very few African countries do newborn screening. We can also extend it to genetic diagnostic before birth, but we know from our own work by implementing this technique in Cameroon about 15 years ago and in Cape Town here about 10 years ago, that the uptake is conditioned by the difficulty faced by parents living with children with sickle cell disease. And the uptake, for example, in Nigeria and Cameroon is very high for genetic diagnostic before birth, but nearly zero here in Cape Town where I work because of optimal care provided to patients with sickle cell disease. We also know that the reproductive action associated with genetic diagnostic before birth pose an important ethical challenges as based on numerous work that we have on work done in Africa, which means that one of the things that we want to focus our attention to is a measure that can allow secondary prevention of complication of sickle cell disease in addition to newborn screening. The implementation of newborn screening, penicillin prophylaxis, the use of Adaxuria have dropped the mortality in children to nearly zero in America, but the mortality in adults have not changed over the past 40 years in America. So you can imagine that in Africa, we will have a worse situation because very few countries have implemented newborn screening, as we have shown in the map before. And that means that in many parts of the world, both Africa and all the other nations that have more resources, we have problem of solving both children mortality and adult mortality. Adult mortality in America, for example, will be due to chronic cardiovascular complications, as shown on this picture. And my presentation will be a little bit biased toward genetics. I'm, after all, a geneticist. And we try to convince the community that sickle cell disease will represent a best model to investigate both monogenic disease and complex threat, because this is a disease that is monogenic, but is also subjected to environmental factors, but also to other genetic variants that condition its severity. This may be probably the reason why the lethality of sickle cell disease is not 100%, even on African continent. Even without treatment, we know that the lethality will be around 80%, not 100%. Kidney dysfunction, for example, is subject to genetic variation, including for the study that we perform here on the African continent. And at least 3 or 4 variants will explain most of the highly associated kidney dysfunction in sickle cell disease. Some of the early studies performed with our student Kutala show that there may be some variant that are associated with pain in sickle cell disease. And some other study in America have shown that using a Bayesian model, you may be able, a mathematical model, to predict stroke using a combination of variant in multiple genes, and or using a peripheral transcriptomic to classify a patient as highly likely to die or not to die. But the most important modifier of sickle cell disease have been fetal hemoglobin, the level of fetal hemoglobin. This is a hemoglobin that is produced during our fetal life that normally become very low in adult life, near to zero. But patients that keep the capacity of keep producing fetal hemoglobin have a longer life expectancy. And this has been shown at least 40 years ago in the cooperative study in America. This is fetal hemoglobin is a quantitative trait that is inheritable, that is also subjected to genetic variation. Studied in Europe, in America, in Tanzania from Julie work, and in our own work in Cameroon, have shown that these variations are very much common in all sickle cell disease patients in the world. And this knowledge have allowed to cure a patient or mice with sickle cell disease by deleting, for example, an important transcriptional repressor of sickle cell disease. In other words, a gene that stops the production that repress the production of fetal hemoglobin. And when that discovery was done, everybody was very enthusiastic by saying that actually, if we stop the expression of that gene BCL11, we're going to cure sickle cell disease. But it was not that simple, because experiment from nature illustrated in these children that naturally have a deletion of BCL11 shows that they actually have an increased level of fetal hemoglobin, but they also have some level of mental disability and some brain malformation, making BCL11 a quasi undruggable drug genes. Fortunately, the team of Stuart Hawkins in the West Coast in the United States, East Coast in the United States, in Boston specifically, have shown that there are some variation in the enhancer of BCL11, that is upstream of BCL11, that is specifically expressed and with some in the red blood cell. That means that if you modify those variations, you can modify the expression of only in red blood cell. And by modifying, they clearly show using cell model that you increase the level of fetal hemoglobin, but only in red blood cell, which increase the prospect of using that variation for treatment of sickle cell disease. If I can summarize this in a layman term, BCL11 is a transcriptional repressor of fetal hemoglobin. Without BCL11 expression, you have an increased level of fetal hemoglobin. You will cure your child with sickle cell disease, but you will have some neurodevelopmental abnormality. But if you modify an enhancer that is upstream of BCL11, a controller of the controller, you will increase the level of fetal hemoglobin without other problem. And this will be the perfect approach to cure sickle cell disease. This is the way this year a few reports on gene editing have been published for sickle cell disease, offering a lot of hope for many of the patients that we have on the African continent. We believe very strongly in a paper that we published a couple of days ago in Nature that the key for sickle cell disease therapy is within genomics, either by modifying fetal hemoglobin, modifying loci, or by using RNA therapy for treatment of sickle cell disease. One of those options, for example, may be exploring microRNA for treatment of sickle cell disease. Our own work have shown that microRNA was very important at the mechanism of hydroxyurea-induced fetal hemoglobin in treatment of sickle cell disease. And many other people's work, even recent work, have shown that this microRNA was very important for post-transcriptional modification of expression of fetal hemoglobin, which means that in the years to come, by investing sufficiently research on microRNA, we can imagine using a microfiber to package those microRNA and provide alternative treatment by injecting directly them in bone marrow. The advantage of this is that we will not be targeting only one gene, but a whole pathway of fetal hemoglobin expression. The development of vaccine for COVID-19.
Just to let you know that you're a bit over time already.
Okay, thank you. The development of vaccine for COVID-19 have given a possibility of also using a messenger mRNA for production of fetal hemoglobin or for a normal hemoglobin. But this is not the end of the story. We believe that in Africa, we will be able to find other low target for fetal hemoglobin if we use the appropriate GWise array to explore it, for example, using the one developed by H3 Africa, and to respond to the need of the patient that are requesting. There are other questions that we have raised in that paper. For example, the evolutionary dynamic of sickle cell disease. We know that this condition has been in Africa for a very long time. Possibly Tutankhamun had sickle cell disease. That means that the pressure of the mutation on our own genome have been very high. It is possible that some variants have been selected in our genome because of the condition itself. This is a proof from an analysis that was performed by Professor Emil Chimusa that identified a few variants, possibly due to the pressure of selection on sickle cell disease on our genome. This is the work that we published this year, and also in that paper you will see this chart that shows that most of those, the non-variant under selection, actually are expressed with sickle cell mutation in many patients. So we still need to have a lot of work to know what is the impact of this variant to designing a genetic risk model for sickle cell disease. And lastly, it is still important we keep investigating the origin of the mutation and how the mutation spread around the world and at what time and for what reason. So hopefully we have now a good network for research on the continent, starting with Sickle in Africa Consortium between SADC and SPARCO, Sickle Gen Africa under the leadership of Solomon, the Sickle Cell Disease Ontology that was started by Nikki Mulder, and the Sickle Pan-African Network that will be the umbrella under all these organizations. It's the time for me to thank our colleague from that for their support, to thank all the people that have participated in this meeting, from the attendees from many countries to the funders, and also to Lancet Hematology and other journals supporting this meeting. Thank you very much.